My name is Dr. Roheen Raithatha, and I'm a fellowship-trained rhinologist at ENT and Allergy Associates in New York City. I'm also on faculty at the Department of Otolaryngology, Head and Neck Surgery at the Icahn School of Medicine at Mount Sinai. I'm going to be presenting a case using VivAer to treat both static and dynamic nasal valve collapse. This patient is a 24-year-old male who had a prior septoplasty and inferior turbinate reduction in 2016 at an outside institution and still continued to have nasal airway obstruction. In 2020, he then underwent spreader grafting to treat his nasal valve collapse with ear cartilage grafting. This was also done at an outside institution. He continued to have nasal airway obstruction in both sides of his nose. He does have a history of a severe pollen, grass, and weed allergy and mild to dust mites, and has failed Flonase, Claritin, and Astelin sprays. He has a mild obstructive sleep apnea and had been using AutoPAP, but was having a lot of trouble continuing to use it due to his nasal airway obstruction. He presented to me looking for options to avoid going back to the operating room, given that he's had 2 prior operating room surgeries. He had a nose score of 65, and on exam has large inferior turbinates and has severe both left and right dynamic and static nasal valve collapse with significant redundant tissue in his lateral wall. This does improve with a modified caudal maneuver in the office. So we had a discussion of options. Given that he wanted to avoid the operating room, we discussed addressing the lateral wall as a starting point in the office with the VivAer device. We decided that we would not touch his inferior turbinates to see how he would do with lateral nasal wall surgery alone. We also did discuss that doing the VivAer procedure in the office would not burn any bridges for the future, and if he needed to have a functional rhinoplasty in the future, I would not be distorting his anatomy to the point where he would have any difficulties in the future. So pre-procedure, he had a nose score of 65, as we mentioned, and here we're going to see both his left and his right endoscopic videos, where we're going to see that he has static collapse at baseline with the lateral wall, the upper lateral cartilage, touching the nasal septum on both his left and his right sides. And then upon inspiration, you can see the dynamic collapse and how the upper lateral cartilage further touches the nasal septum. He had such a limited airway that I was not able to even pass the scope easily to look at his inferior turbinates and his posterior nasal cavity and nasopharynx unless I pushed that lateral wall over. He then underwent the VivAer procedure in the office, where we used radiofrequency ablation to treat the lateral wall on both sides. Immediately post-procedure, on his left side and his right side, you will see that he has an improvement in both his static and dynamic nasal valve collapse. We can already see space between the upper lateral cartilage and the septum on both sides, and upon deep inspiration, we no longer see that complete collapse. He had a nose score of 0 immediately after the procedure, and he exclaimed to me that he had never breathed better in his life. These results were sustained out to 3 months, and now even out to 6 months. At his 3-month follow-up, he had a nose score of 10, and you can continue to see that he has improvement in both his static and dynamic nasal valve collapse, where he has space between his upper lateral cartilage and his nasal septum, and you no longer have that complete collapse upon deep inspiration. He is breathing better than he ever has in his life now, he has told me, and he's also sleeping better, due in large part to the fact that he can actually tolerate his AutoPAP for his mild OSA now. He's very happy with his 6-month results so far, and is most thrilled by the fact that we were able to treat his lateral wall collapse in the office without having to put him under general anesthesia in the operating room. Now, one of the reasons why I think he did so well was that he had both static and dynamic nasal valve lateral wall collapse that we were able to address. Now, one of the reasons why I think we were able to improve his dynamic nasal valve collapse is that by increasing the radius of his internal nasal valve, there's reduction of the negative pressure inside the nose, which prevents the lateral wall from further collapsing. So I hope you enjoyed seeing this case where we were able to treat both static and dynamic nasal valve collapse in an office-based setting in a patient that has undergone 2 prior nasal surgeries in the operating room.